I am Dr. Leslie Benson. I'm in Boston, Massachusetts. I'm a pediatric neurologist, and I'm going to talk to you today about a project we're working on called Misdiagnosis in AFM. I don't have any disclosures relative to this talk. And I just want to start with a case. And this is one of the many cases that got me interested in this project. And I know there's been others all over. So this is a healthy 5-year-old boy who 4 weeks prior to arrival in our emergency room had fallen off his bike, had a right forearm fracture, and was typical for about 2 weeks. And then 2 weeks before his presentation, he started with weakness with fever. So he had a fever to about 100.1 or 100.2. Had some initially neck pain, progressed to back pain, and then those got better and progressed to limb pain. And he was then unwilling to move, wasn't walking as well. And mom gave a great history of the fractured right arm was first weak, and that progressed to left arm, and then to leg seeming weak, and he had some incontinence. Whether that incontinence was because he couldn't move to get to the bathroom or because of neurologic dysfunction isn't totally clear, but he also had some significant constipation, so certainly could have been neurogenic as well. He had multiple visits with his orthopedist, with his PCP, and kind of initial diagnoses included attributing it to his fracture and being in a cast, and thinking that he had Lyme disease, but ultimately testing came back negative. So eventually he ended up in our emergency room a couple weeks into his symptoms. And by that point, he was actually starting to get better. His walking was better, but he was still pretty weak. This is his imaging. You'll see, notice a lot of features that Olin just talked to us about, but in the middle, you can see that he has this anterior cervical lesion that is on the axials here with clear gray matter involvement, right side predominant, and on other axial slices. Really, it was very much just in the right anterior horn at this point in time. And then another beautiful example of that anterior nerve root enhancement that can be seen later in the disease course. He also had just a few pertinent labs among the many sent with an ongoing CSF pleocytosis that was lymphocytic predominant and a pretty elevated protein at that point. And while initial NP swab was positive, result is positive for enterovirus, typing at the CDC ultimately was significant only for rhinovirus A101, so likely unrelated, and really wouldn't have expected 2 weeks in to find much. So you've already heard a lot about the differential of AFM, particularly the neurologic differential, which is on one side of the table, but I want to direct you to the right side of the table and to the many different diagnoses that we have seen that sort of contributed to our interest in this misdiagnosis project. So this case with the sequelae of fracture being one example. We've also seen patients who were thought to have brachial plexus injury initially, toxic synovitis of the hip. This shoulder injury related vaccine administration was one that came up, and then functional neurologic syndrome and just nonspecific URI related symptoms. So you might say, I guess with this group, I don't think I have to argue with anybody that diagnosis is urgent and valuable to the patient and the provider, but thinking about the reasons why acutely, the risk of respiratory dysfunction or aspiration is real. There's this case report of a patient who was not hospitalized and had a fatal outcome at home, and I think speaks to Sarah's points of why we observe patients in the acute setting. Fortunately, my case was fortunate, and he didn't get that severe. There also are the arguments, as Kevin mentioned, with trying to get samples early and more higher yield, and then I think there's hopefully treatment relevance. It's particularly in this condition, if a treatment is going to work, it may have to be given extremely early in the disease, so it needs to be recognized. And then I think something that's under emphasized is the importance of just a correct diagnosis for the patient and family, as well as the providers who are trying to guide expectations and management. So for all of these reasons, we were having conversations about the many differentials that we've seen for our patients, and I have to give credit to Sarah Hopkins, who sort of helped, drove the conceptualization of this project. And we decided to reach out to the AFM working group and design this study looking at misdiagnosis and potential contributing factors. So we have 13 institutions within the AFM working group who have contributed to our study, many of whom may be on this call and are presenting. Each site did a retrospective chart review, and the inclusion criteria for the study was for patients who had onset of disease before 18 years of age, met the CDC case definition that was relevant in 2018, and patients who had presented between 2014 to 2018. We defined misdiagnosis as either an alternate diagnosis that was given prior to the AFM diagnosis, or if a patient was evaluated by a medical provider and discharged home without a specific diagnosis that we could elucidate from the chart review. So this is our initial results. We have 175 patients in our cohort, and the vast majority are misdiagnosed. So there are 137, or 78% of the cohort had an alternative or no initial diagnosis, and only the small proportion, 22%, were promptly diagnosed at their first encounter. This is a graph representing only a proportion of the whole cohort that we looked at, and Sarah Hopkins presented at AAN last year, and really just want to emphasize that it mirrors the CDC epidemiological data, but also that the misdiagnosed, which are highlighted in orange, are a very prominent portion of the patients in each of the 3 years where we saw peaks and were studied. So this is the many alternative diagnoses that were given. So I'm just going to spend a little bit of time walking you through this page. So at the top, you see that all diagnoses, we have 140, which is more than the 136 that, or 135 that were misdiagnosed. And that's because some of the patients received multiple differential diagnoses or multiple diagnoses prior to their AFM diagnosis. And we looked at the acute neurologic conditions that were misdiagnosed, and many of which multiple speakers have addressed earlier in the day. And those are over here in the orange. They're really diagnoses that we'd expect would bring patients to acute care and likely prompt neurologic evaluation. And so we felt like really these diagnoses are very appropriate differential and would also lead towards a similar diagnostic workup. So we sort of grouped them together. And there are things we've been talking about: Guillain-Barré syndrome, transverse myelitis, as well as CNS diseases. So things like other spinal cord pathology like stroke, ADEM, autoimmune encephalitis, and cerebral stroke as well. In the middle here, we have the middle blue, a small subset that were diagnosed with a non-acute potentially neurologic diagnosis, but wasn't necessarily expect to come to a neurologist or a hospital quickly. So things like Bell's palsy and plexopathy or neuritis. Really, we are very interested in the large blue portion on the right, the non-neurologic diagnoses that were given. And there's many different diagnoses that are given, but I think a few big categories where most of the patients fall. I do want to point out that 5 of the patients were given conversion disorder, and then 19 were labeled with musculoskeletal conditions. So those varied from toxic synovitis of the hip, myositis, fractures or sprains, one other patient besides the one I described, torticollis, and other nonspecific conditions. And then there was a few nonspecific para-infectious autoimmune conditions, and then a large portion that were recognized to be infectious, but not necessarily neurologic or something that would come to a neurologist's attention. There is so meningoencephalitis, I think you could argue, might bring you to the hospital or to a neurologist's attention, but not always. And so we put it in the blue category. And then there were nonspecific viral illnesses and sort of a smattering of other conditions that were found in the cohort. We found a few associations so far in our dive into the data. And when we're looking at the misdiagnosed versus the promptly diagnosed groups. So somewhat to our surprise, we found that there was a higher rate of ICU admission in the misdiagnosed patients and a trend towards a higher utilization of ventilatory support, both invasive and non-invasive ventilation. And there was a delay in diagnosis, and by about 2 days on that, taken an average, and 1 day delay in initial treatment being administered. So this, I just want to leave you with a few kind of tips to think about that I like to give to pediatricians and emergency room doctors when giving talks to help encourage people to think about AFM. Keep that in the differential so that we find that needle in the haystack and can appropriately monitor and hopefully treat these patients. So this is my table just going over things that can be done in the history and the exam to not miss these patients and to figure out that there's something other than everything on that algorithm I showed you. Last, I want to say thank you. As you can see, there's a long list of people who've been involved with this project, particularly Leslie Hayes, one of our stellar residents, who has put a ton of time and energy and effort into this project, and our statisticians and the many physicians and others who have chart reviewed and sent us data from centers that are involved in the AFM working group. Thank you, thank you, thank you. And that is into my talk. Next, we get to hear about another very important study with David Kimberlin, talking about the NIH Natural History Study.